but he's answering my emails, so I appreciate that.
Hmm.
All right. Well, it looks like it is 4:01, so our obligatory 1 minute time to join Grand Rounds. So it's my pleasure this afternoon, and I know people often say that when they're introducing speakers, but I really do mean it. It's really my pleasure to introduce today's speaker, Dr. Brad Javorsky. So I have known Brad since we were both fellows in training. I believe that we met in Toronto.
Sounds right.
That was some 16 years ago-ish. So Dr. Javorsky completed his undergraduate work and medical school at the University of Wisconsin-Madison before he moved to Virginia to pursue his residency and fellowship training. I would say we were very lucky to recruit him here to the Medical College of Wisconsin in 2008, where he joined me in July of 2008. And it was the two of us acting like we knew what we were doing at that point. But certainly he is an expert in several areas, and I've been very fortunate to work with Brad in a number of different projects, including several trials for the treatment of Cushing syndrome, and really what he's going to talk about today in adrenal insufficiency and diagnostic methods. So it really is my pleasure to introduce Brad. The floor is yours.
Well, thanks, Ty. That was very kind. I was a little worried you could have made that very painful for me, so so I do appreciate your nice introduction. The motivation for this talk actually goes back a couple years when we were approached by the lab at Froedtert, who was then led by Dr. Jessica Colan Franco, who said to us that the lab was going to be retiring an old cortisol assay, one that we've had for many, many years, and they would be replacing it with a new one because the manufacturer was no longer making the older cortisol assay. So we got together and decided to run samples on patients simultaneously using different cortisol assays, including the older cortisol assay and the new cortisol assay. And it was really intriguing results because it made me realize that things we consider as just kind of facts, things we learned in medical school, can change over time. And so I'm going to share some of those results with you, and hope you find it as interesting as I do. Okay, these are my disclosures. The objectives today are to review the pathophysiology and differential diagnosis.
Please record your message.
Of adrenal insufficiency, to discuss various methods used to make the diagnosis of adrenal insufficiency, and to understand new assays and cutoffs used to make the diagnosis. So for those of you who are history buffs, the discovery of the adrenal gland is attributed to this Bartolomeo Eustachius back in 1563, and he called the adrenal glands the glandulae renibus incumbens, and he described them in his anatomy text as both kidneys are capped on the extremity towards the cava by a gland, both are connected by a fold of the peritoneum in such a way that one, if he is not very attentive, does not really overlook them, as if they were not present. Their shape resembles that of the kidneys. Sometimes one is bigger, sometimes another. And then, of course, Thomas Addison is credited with describing a syndrome of adrenal insufficiency for the first time and presenting it in his famous monograph in 1855 on the constitutional and local effects of disease of the suprarenal capsules. And this is a really interesting read if you ever get a chance, just to kind of look through this. It's the case presentations and description of patients with symptoms. You can actually see these books online, the original book and the original pictures. So I went online and looked it over and looked at some of the books, and I looked at it and I said, I wonder who was the first person that actually checked it out from the library. And sure enough, I recognized a couple names from back in the day who checked it out when it first came out. But seriously, there are some really interesting pictures in this monograph if you ever get a chance to look it over, and you can appreciate that a lot of these patients have symptoms and findings that we see still today, like the hyperpigmentation that's shown in this person here, as well as some findings on pathology. In this case, it was bilateral metastases to the adrenals as the cause of adrenal insufficiency in this patient. And I think we're all familiar with the hypothalamic pituitary adrenal axis. The limbic system with stress can activate the hypothalamus, which can release CRH and vasopressin, causing release of ACTH from the pituitary, and then ultimately cortisol and glucocorticoids from the adrenal gland. These feed back on different levels of the pituitary, hypothalamus, and hippocampus. With primary adrenal insufficiency, we have a defect in production or secretion of cortisol from the adrenal gland. And with that, we see low cortisol levels, high ACTH levels, as well as low aldosterone and high renin activity. With central adrenal insufficiency or secondary, tertiary adrenal insufficiency, you see the low cortisol and low or inappropriately normal ACTH levels, but the aldosterone levels are within normal limits. The different causes of primary adrenal insufficiency or Addison's disease. Nowadays in the United States, the most common cause is autoimmune, either as part of an isolated condition or polyglandular autoimmune syndrome. Back in Addison's days, the most common cause was infectious, like tuberculosis. Metastases, usually from breast or lung, colon, or lymphoma, can cause primary adrenal insufficiency. Hemorrhage or infarction. A number of different drugs can cause it. Things like ketoconazole, fluconazole, etomidate, mitotane. And then a number of rare conditions, genetic conditions like adrenal leukodystrophy, congenital adrenal hyperplasia, familial glucocorticoid deficiency, and familial glucocorticoid resistance. Secondary or tertiary adrenal insufficiency has a number of different causes as well. Some of the most common are masses in the pituitary or hypothalamus, like craniopharyngiomas, large pituitary tumors or metastases, trauma or radiation to the pituitary or hypothalamus, drugs like opiates or high-dose progestins, cessation of glucocorticoid therapy or correction of Cushing's syndrome, infiltrative diseases like hemochromatosis, sarcoidosis, or histiocytosis, infections, infarction, and then again, rare genetic conditions like POMC deficiency, TPIT gene mutations, or familial CBG deficiency. Symptoms of adrenal insufficiency are sometimes vague and hard to pin down on adrenal insufficiency specifically. So things like fatigue, weight loss, dizziness, anorexia, abdominal discomfort, and salt craving. Signs of adrenal insufficiency are hypotension, so low blood pressure, hyperpigmentation in primary adrenal insufficiency, abdominal tenderness, and reduced consciousness. The history can often provide a clue to adrenal insufficiency. So if the person had recent pituitary surgery or radiation to the brain, trauma, head trauma, or medication use that would cause adrenal insufficiency. Tests that might hint at adrenal insufficiency include low sodium levels, hyperkalemia with primary adrenal insufficiency, low blood sugars, or high calcium levels. And then imaging may reveal bilateral adrenal masses or enlargement and pituitary or hypothalamic masses. Making the diagnosis of adrenal insufficiency can be very difficult because there's a big overlap in ACTH and cortisol levels between normal individuals and those who have mild disease. There are large fluctuations in cortisol and ACTH under normal circumstances. This is a curve, a 24-hour curve of cortisol and ACTH, and you can see that over that time period, there's a lot of dips and swings in cortisol and ACTH. Levels are highest early in the morning, around 8 or 9 o'clock in the morning, They decline during the day, but can increase with food intake, and are lowest overnight. Making the diagnosis, though, is very clinically important, because if you miss it, it can result in death from adrenal crisis. On the flip side, if you diagnose somebody with adrenal insufficiency that doesn't really have it, you can cause a lot of different complications by treating them with long-term glucocorticoids. So a number of different diagnostic tests have been used over the years to try to make the diagnosis of adrenal insufficiency. We use basal morning cortisol and ACTH levels, basal morning DHEAS levels, the insulin-induced hypoglycemia test, the mitral stimulation test, the CRH stimulation test, and of course the ACTH stimulation test, which is what we're going to spend most of our time talking about today. Basal ACTH and cortisol levels, if ACTH is very high, then it's strongly suggestive of primary adrenal insufficiency. If it's inappropriately normal or low, this can be seen with secondary adrenal insufficiency. Cortisol, the results depends a little bit on the assay, as we'll see here, but some studies have shown that if cortisol levels, basal cortisol levels, are somewhere in the range of 12 to 18, then you can essentially exclude adrenal insufficiency, and no further testing is needed. On the other side, if the cortisol levels are very low, and studies suggest a cutoff somewhere around 3 to 4, that makes adrenal insufficiency very likely. And again, this depends a little bit on the cortisol assay. In the study we did, we looked at patients who underwent ACTH stimulation testing, and we segregated them into two groups: those who had normal results and those who had abnormal results on ACTH stimulation testing. And you can see in the 4 different assays, the Alexis 1, which was the old cortisol assay that we had for many years, the Alexis 2, which is the new cortisol assay we have, which is more specific, the Axis immunoassay, and then the LCMS assay. And if you separate them into groups that had normal and abnormal responses to ACTH stimulation, you can see that you had to have a level below 2 to be certain that the person is going to have an abnormal response to ACTH stimulation. So it had to be really low, at least in this group of patients, to be certain that they have adrenal insufficiency. DHEAS levels can be a helpful tool to help with the diagnosis of adrenal insufficiency. So in this study, the authors separated people who had abnormal results with ACTH stimulation testing and those who had normal results. And again, you can see that the group that had abnormal results had very low DHEAS levels, and those are in the triangles, whereas those who had normal results were mostly higher with DHEA. Some had lower levels, but the bottom line is you can basically, if the levels are normal, it makes it very, if the levels are low, it makes it quite possible that they have adrenal insufficiency. As people age, their DHEA levels decline, and women tend to have lower levels than men. So there's a number of different tests that are really good, but we don't use them anymore. So I didn't want to spend a lot of time talking about them, but I think at least mention them and touch on them a little bit. So the insulin-induced hypoglycemia test works by causing stress, the hypoglycemia, which stimulates endogenous ACTH production, and then as a result, cortisol should increase. This is considered, or was considered, the gold standard test. And for patients who had recent pituitary injury, it is probably better, maybe better than the ACTH stimulation test. It's good for diagnosing secondary adrenal insufficiency because it stimulates ACTH release endogenously. Some patients who have partial adrenal insufficiency might have a false, you might have a false negative result because you can get a good response to cortisol in patients who have severe hypoglycemia, even if they have partial adrenal insufficiency. But this test has really been abandoned because it's just too dangerous. It requires somebody to sit by and watch patients, and you can't do it in people who have a history of heart disease or cerebral vascular disease or a history of epilepsy. So this is just not a test that's really done anymore. The metyrapone stimulation test works by inhibiting 11 beta hydroxylase in the adrenal gland, and as a result, cortisol drops, which then causes an increase in ACTH and 11-deoxycortisol, which is a precursor to cortisol. This test really isn't done anymore because number one, you can't get it. It's really hard to get metyrapone. And the 11-deoxycortisol level that you measure takes a long time to get the result back, so you have to send it off to a reference lab. And really, studies have not shown that it's really any better than the ACTH stimulation test. So for a number of reasons, we don't really do the metyrapone stimulation test anymore. The CRH stimulation test works by directly stimulating the corticotropes, and this is good at identifying secondary adrenal insufficiency, but it's very expensive and you can't get it anymore, so it's not really a test that is done anymore. The low dose or 1 microgram ACTH stimulation test, it was thought that maybe it would be a more physiological way to stimulate the adrenal glands. It's a lower dose of ACTH than the standard higher dose ACTH stimulation test. But this also is not done very much at all for a number of different reasons. First of all, in meta-analyses, the diagnostic accuracy was found to be similar. There's no vials of 1 microgram ACTH available, so the pharmacy has to dilute it. And very small errors in dilution or using the wrong tubing where it binds to the tubing can result in a pretty large overall percentage change in the dose. And that change in dose can result in huge variations in cortisol results. So, and finally, it's not useful for assessing the aldosterone secretory capacity. So it's just not a test that is done very often anymore. So that brings me to the ACTH stimulation test, or cosentropin, 1 to 24. So the high dose test is considered the 250 microgram dose, and that's given IV or IM. And it assesses the adrenal response to a very high level of ACTH. Cortisol is typically measured at 0, 30, and 60 minutes. And one caveat is that if the patient had a recent injury to the pituitary or hypothalamus, you might get a false negative result because the adrenal glands haven't yet atrophied. So the idea behind this test is that the cortisol secretory rate really hits a maximum level with an ACTH concentration of 130 picograms per milliliter. And with the dose that we give in the ACTH stimulation test, the levels measured are over 60,000. So it's way, way above the physiologic amount. So if there's any cortisol that can be made, this test should be able to stimulate it. This test just shows, this is just a study that looked at 35 control subjects, and we can see that the ACTH levels are really high after injection of 250 micrograms. There's been a number of ACTH stimulation testing controversies over the years, and many different people have tried to answer these different questions. So, for example, what time of day should it be done? Another one is, what's better, the high dose or the low dose? And we talked about that a little bit. What's the best time point for measuring cortisol? Should it be at 30 minutes? Should it be at 60 minutes? Should you use a peak cortisol, or should you use a cortisol increment, change in cortisol between the baseline and 30 or 60 minutes? And then finally, what is the cutoff for ruling out adrenal insufficiency? So these have been all areas of intense investigation over the years. The first one, the time of day, the good news is that there's very minimal impact on the time of day. So you should be able to do this test at just about any time of day. In this particular study, they segregated the the patients into those who had it between 8 and 10 a.m., those who had it between 10 a.m. and noon, and then those who had it after noon. And there really was not much of a statistical difference in the results. The baseline level was a little bit lower as later in the day, which is not surprising. But for the most part, there was no statistical difference in the results depending on the time of day. You may have a few less false positives if you did it in the morning, but other than that, there's really not much of a difference. So the time of day shouldn't matter, which is a good thing. The timing, when do you actually measure cortisol? As you can see here from this curve, cortisol levels increase with the 250 microgram high dose stimulation test. They increase and hit a peak not until after 60 minutes. And so it's always higher at 60 minutes than at 30 minutes. So you'd think that the cutoffs would probably be different for those two time points. With lower doses of ACTH, the peak is much earlier, and that's one of the problems because you have to measure the blood more frequently at more frequent times earlier on. So that brings us to the guidelines that are still the most updated ones from the Endocrine Society. This is from 2016. I think a lot of people are very familiar with this, and I just wanted to point out a couple interesting things from this guideline. Number one is that this is for primary adrenal insufficiency. So they're focusing more on primary adrenal insufficiency. Some people might argue, well, if you have primary adrenal insufficiency, the ACTH levels are really high, and for many patients, you may not even need to do additional testing. But they recommend as the optimal test the high dose ACTH stimulation test, the 250 micrograms. And they recommend doing it at 30 or 60 minutes to look at the peak level. And they use this cutoff of 18 micrograms per deciliter. This is the cutoff that I think most people are familiar with. This is that I was taught in medical school, and I think a lot of people have just learned over the years, and it's just become ingrained in our psyche that that's the cutoff is 18 micrograms. Now they do to their credit, they do kind of throw in there and say that it's assay dependent, but still, most people still think of this 18 as the cutoff. I tried to ask the question, where does this come from? Who first came up with this cutoff? And I went back as far as I possibly could. And the first study that I could find that did ACTH stimulation testing was this study by Wood in Lancet in 1965. And so he used 5 control subjects and an older assay, a fluorometric assay, which had a lot of cross-reactivity between cortisol and other different glucocorticoids. And they know it, and they mentioned it in their study. But in this study, they used the ACTH 1 to 24, which is in the figure, it's labeled as beta 1 to 24. But that was one of the first ones that this is the first study that really came out looking at this stimulation test. And you can see that at least in this test, the peak was somewhere around 30 at 60 minutes. So for this one, normals, the peak was 30. But again, this was an older assay where there's a lot of cross-reactivity with other glucocorticoids. They also commented on the increment in cortisol, and they said it ranged from 7.5 to 27.5 in normal individuals. So this was another topic that they kind of brought up as far as what the cortisol increment should be. So, here's the problem. Many laboratories have switched to more specific cortisol assays, and you'd think that they should have lower cutoffs because they're more specific. You don't get as much of the cross-reactivity to other glucocorticoids. Unfortunately, these new cutoffs have not been derived for many of these assays, and they've not been well publicized in the EMR. And when you use a cutoff of over 18, when it should probably be lower, that could lead to the overdiagnosis of adrenal insufficiency, and as a result, unnecessary treatment. So this is the problem that we're dealing with. and we've seen over the last couple of years, there's been some studies that have shown this. So in this particular one from 2013, normal subjects were used, and cortisol levels 30 minutes after ACTH stimulation were obtained, and a number of different assays were performed. The E170 is the one that we used to have here, the older Roche cortisol assay, and I put there to the side the approximate cortisol level cutoff for males and females, which is pretty similar. But you can see that with the more specific assays like GCMS, the cortisol was lower, 15.2, as compared to these less specific assays where the cortisol level was higher, anywhere from 17 to 20. In another study, a group from France used the assay that we used, the Alexis Cortisol 2. The Alexis Cortisol 2 assay compared to the Alexis Cortisol 1. And this is the assays that we have here at Freidert. And what they did is they looked at patients who had ACTH stimulation testing or insulin-induced hypoglycemia, and they defined normal as a peak cortisol under 18. And so what they found is that using this newer, more specific assay, they had to drop the cortisol cutoff to 13.5 in order to achieve a good sensitivity and specificity level. And so again, they found that, wow, the cortisol cutoff had to be much lower than 18. All right, so something happened here. Somehow I got started annotating rather than.
There might be. It looks like you've got the laser pointer thing or the annotate. Like maybe at the bottom of the screen, there's a PowerPoint. It's got the little.
Well, so it asked me to annotate, and now I'm annotating, but I don't know how to unannotate.
Might be able to use the keyboard to advance too.
Yeah, I'm trying, but there's.
In that case, I give up.
If you click on the dot that shows the annotate at the bottom, that's what I'm seeing. Can you, will it undo it?
No, I don't. Can you undo it? Are you able to unannotate? I got a message saying that somebody requested to annotate, and
that might have been me trying to help you out. You might need to go to the left-hand side of the screen. At least that's where it is on my WebEx, and there's an ask to annotate thing. You might be able to unannotate it there.
nope, it won't let me advance here now. Somehow it signed me up to annotate. Now I can't.
Maybe you can unshare and come back, right?
Okay.
I don't even know if unshare is a word, but I made it up.
All right, let me share again. Okay. So I think we were here. Okay, so the sorry about that. So our goal here was to compare the gold standard cortisol assay, which is the Roche Alexis Cortisol 1, which is the one that our lab had for many, many years. And for that one, the cortisol cutoff was felt to be 18 for the ACTH stimulation test. And we decided to compare it to the new assay, which is a monoclonal assay, which is more specific, as well as to the Beckman axis cortisol assay, which is polyclonal, and the LCMS-MS cortisol assay, which is very specific. The latter two assays were done at the Mayo Clinic, so we shared samples with them, and they ran those tests, those samples on those tests when available. These patients were hospitalized and ambulatory, and they were suspected of having adrenal insufficiency. So what we found, first of all, was that when you look at the different assays, the 60-minute sample was always higher than the 30-minute sample, and it was similar across the different methods. And one of the important, I think, observations is that it was always about 2 micrograms per deciliter different. So that was one of the differences, or one of the observations that we saw for this particular comparison. Another thing we did is we compared all the different assays and calculated the slope using Deming regression, and you can see that from this picture you can see that it looks very tight. There's a very high correlation between the Alexis Cortisol 1, the old assay, and the newer assays. So there's a very nice tight correlation. But one of the issues is that the slope is not 1. So if it was 1, then you'd expect 18 on the old assay to be 18 on the new assay, but because the slope is less than 1, then then there must be a difference between the values. So if you look at 18, this cutoff that's very commonly considered the cutoff for adrenal insufficiency, on the newer assays, the cutoff would be closer to 14 or 15 based on that slope. And again, this is assuming 18 for 30 or 60 minutes. And as we saw, the 30 and 60-minute time points are different. It's always higher at 60 minutes, so you would expect the 60-minute cutoff to be different than the 30-minute cutoff. So if you looked at 20 as the cutoff for the old assay, then using the new assay, the cutoff at 60 minutes would probably be somewhere around 15 or 16. Another observation is that if you use 18 as the cutoff on the old assay, 16 out of 110 of our patients would be labeled as having adrenal insufficiency. That's 14.5%. If you used 18 as the cutoff on the newer assays, the percentage of patients who would be considered to have adrenal insufficiency would go way up, 29%, 32%, 22%. So obviously there's the potential for a lot of false positive diagnoses if 18 is used as the cutoff. No patient in our study with an abnormal Alexis 1 value less than 18 were normal on the Alexis 2 axis or LCMS assays. So nothing was missed with the newer assays. 9 out of 110 patients had abnormal values at 30 minutes, but normal values at 60 minutes. And of those 9 patients, only 1 was clinically thought to have adrenal insufficiency. So this would suggest that the 60-minute time point might be a better measure of adrenal insufficiency than the 30-minute time point. 8 of 110 patients had normal values on one assay, but abnormal values on a different assay. But all of them were normal on the Alexis 1 assay, which is the one that we use. Not long after this study was published, a letter to the editor made an observation with a different assay. So this is an assay that we don't use, the Abbott Architect, which is another monoclonal antibody, and they compared it to the Alexis 2 assay, the one that we do use, and they did it in 59 samples, and their regression slope was about 0.8. And they found that if you use a cutoff of 15 with the new assay, or the Roche cortisol 2 assay, that they would have a cutoff of 13.9 with their assay. So this is just one more data point that is being published showing that some of these newer, more specific assays have lower cutoffs. To make some conclusions, to make an accurate diagnosis of adrenal insufficiency, a combination of clinical and biochemical data are necessary. I can't emphasize that enough, that you can't just look at test results and put all of your money on that. You have to make a clinical diagnosis. Cortisol, ACTH, and DHEAS levels can be helpful in the diagnosis of adrenal insufficiency, although only really high or really low cortisol levels will obviate the need for further testing. Insulin-induced hypoglycemia, the metyrapone test, the CRH test, and the low-dose ACTH stimulation test should rarely be used. And the ACTH stimulation test, high dose, 250 micrograms, is the provocative test of choice to make the biochemical diagnosis of adrenal insufficiency. The peak cortisol should be used rather than using the cortisol increment. ACTH stimulation testing can be done any time of the day. Cortisol peaks 60 minutes after high dose ACTH administration, so the cutoff values should probably be different at 30 and 60 minutes after ACTH administration. Cortisol assays have different specificities for cortisol, so these cutoff values are likely different depending on the assay used. So it's important to know which assay is used at each institution. So ideally those would be published, and clinical labs should also post cutoff values for cortisol if they're known. And so then, the bottom line question is, well, what cutoff should we use? And it's hard to say. Again, it depends on the assay, but when you look at some of these newer, more specific assays, I'd say that a cutoff of 14 to 16 at 60 minutes is reasonable, and 16.5 to 18 at 60 minutes is a reasonable cutoff. But really, we need our good prospective studies that test people to make sure they really do have adrenal insufficiency, and then we can find out what the true cutoff should be. So this is an algorithm that I kind of put together. I adapted it from an algorithm in this paper down here, but I made some changes based on different cortisol cutoffs using newer assays. And I think, a good approach to starting off with the diagnosis involves getting a baseline serum cortisol, ACTH, and DHEAS levels. And again, this is in the ambulatory setting. A cortisol less than 3 with a low DHEAS level basically confirms the diagnosis of adrenal insufficiency, and then the next step is to look for causes and begin therapy. A cortisol somewhere in the gray range of 3 to 10 should then undergo ACTH stimulation testing. If the cortisol is a little higher, 10 to 15, but the DHEAS is low, ACTH stimulation testing should be the next step. However, if the ACTH and the DHEAS levels are normal, then no further testing is probably needed unless the clinical suspicion is really, really high, in which case, further testing or repeat testing might be a good idea. And then again, if cortisol levels are over 15, no further testing is probably needed. And then I just have to, thank all the people that I've worked with over the years, because I've learned so much from them, and they've had a major impact on what I do clinically and for research. And so again, I've just learned so much, and even from Ty. So he's helped me out a lot, and I appreciate all that everybody's done with me. So thank you, and I'd be happy to take any questions, and I'll do my best to try to answer them.
Great talk, Brad. So let me actually start with a question. When you kind of gave the cutoffs that you think maybe we should use, you suggested a 60-minute, somewhere in that 16 to 18 range. Why do you think that versus a lower cutoff from some of the other data that would suggest 14? I mean, obviously, you've kind of pointed out it's not perfect.
Yeah, I mean, I think it's based on that observation that the 60-minute value is always higher than the 30-minute value, and the 30-minute value, if you use that as the cutoff of 18 with the older study, that would kind of give you that cutoff of 14 to 15 for 30 minutes. But if you figure that the 60-minute value is higher, then I would say, and again, the observation is that it's about 2 micrograms per deciliter higher. So basically just adding a little bit to that is where that came from. But we need good prospective studies to really figure out what the true cutoff should be.
Hey, Brad.
Yeah.
This is Joe. So I wanted to make sure I understood. You said if the base morning cortisol is less than 3, then did I understand you to say that then you have adrenal insufficiency?
Yes, I think you have it unless, yeah, I think you have to assume that the person has adrenal insufficiency. And in our with the assay that we use, the 2 was the point at which if it was 2 or less, the patient always had adrenal insufficiency. Some assays are not quite as specific as ours. So again, I'm trying to hedge it a little bit with other assays that might be less specific. But yeah, I would say that 3 is a good cutoff. If it's less than that, you can basically say that the person has adrenal insufficiency.
And I think you're right, but I think there's some subtleties with patients that in abroad, like if they're on narcotics and they took their narcotic, some of those patients have a cortisol 3, and then you give them Cortrosyn, and they stimulate fine. Or I've seen that. Seems like I've seen that. Maybe I'm wrong.
No, I mean, there's no question that you have to sort of, take into account the whole clinical picture. There's people who are on steroids for 3 days and somebody happens to check a cortisol on them, and the cortisol's low, but they're only on the prednisone for 5 days. And then, are you going to start that person on long-term steroid supplementation? Of course not.
I think the bigger problem is people on narcotics. I think it's just more common.
No, you're right.
It's more common that people don't recognize it. Obviously, when somebody's on prednisone, I think people know that this can suppress the HPA axis. But I think it's, they get occasional doses of a narcotic throughout the day. The cortisol goes down after it and then comes back up. And I think it can be confusing if they took their morning oxy and then got a cortisol level. I don't know. Maybe that's just
some of these
that observation might be erroneous. I don't know.
Right. No. I mean, I agree, but it's a tough thing to know what to do because some of these patients are on long-term opioids, and you measure their cortisol and it's always a little low. Should they be on steroids? Well, maybe, especially if they have symptoms. But so yeah, I think it's hard to know what to do with some of those patients.
Well, you brought up a good question. And I do think that's a really important question, what to do with people on long-term narcotics that have low cortisols, because I assume most of them don't feel very well.
Mm-hmm.
And we probably should at least give them stress dose instructions.
I agree.
This is Ty again. So, I mean, the one thing about, this is veered off a little bit, but I mean, certainly with the people that are on opioid narcotics, they do tend to stimulate, at least in the ACTH stim tests. And there's a thought that, with stress, they actually stimulate okay. I know that there was some push to look at, patients with opioid induced potentially adrenal insufficiency. I think there was a recent paper about this, but I don't know, Brad, do you, from what you know, have you seen that these patients tend to stimulate, at least when they get ACTH, if they just have narcotics as the cause of their low cortisols?
That's my understanding, is yes, they do stimulate normally.
I have a question, Brad. You mentioned adding DHEA to the baseline cortisol, even if it's so. How important do you think that is? Because if it's less than 3, obviously we're going to take a quick. What do you think the DHEA would add? In what situations it might be more helpful than only cortisol?
Yeah, I mean, I think it's more helpful in probably some of the gray areas. It's one more piece of data to try to build a case that the person has adrenal insufficiency. So I think, yeah, just one more piece of data that if that is abnormal, that really should raise your suspicion for adrenal insufficiency. So.
So do you do that routinely in all patients you suspect AI?
Yeah, I mean, I don't see patients that I suspect for AI every day, but when I do suspect it, yeah, I do get a DHEAS level in addition to cortisol and an ACTH level.
So that's interesting, Brad. I see a lot of obviously older people, and sometimes they have unexplained hyponatremia. And I usually just get a morning ACTH and cortisol. And usually, I would say most of the time, it answers the. I mean, I kind of assume if their cortisol is more than about 10, that they probably don't have adrenal insufficiency. Maybe I'm being too cavalier. But I don't do a DHEA sulfate. It's kind of low in older people, or if they've ever been on steroids, right? I mean,
yeah, that's the problem. Is that the older you get, the DHEAS is normally lower, and like you said, it seems like everybody is gotten some sort of a cortisone injection or topical steroids, and so that can lower the DHEAS as well. So that does make it harder to interpret, especially in older people.
Yeah, I mean, I think if the 3, 2 and 1 or something like that, I think 3 seems, so are you saying that if it's 3 and then with DHEA, we don't really have to do co-syntropin stim test, right? I mean, I think that's the assumption, right, from your
again, I think in the right clinical scenario, definitely. I think if you have a really low suspicion and there's some other explanation for why the cortisol could be low like that, then I don't think necessarily in every case, but I'm trying to talk about, for most people, I think if you suspect adrenal insufficiency and you get a cortisol of 2.5, I would be very suspicious that the person has adrenal insufficiency.
Thank you.
hey, Brad, just a couple comments.
Yeah.
That's great talk. And I also congratulate you on that study, which I think was really important. And I can send you a picture in case you want to put me on your last slide.
Sounds good. I'm sure there's plenty of them on the internet already.
Any other questions for Brad? Well, if not, Lydia, I don't have anything else.
Yep. Thank you, Brad, for excellent talk.
All right. Thank you. Have a nice afternoon.
Bye.
Bye-bye.